So we were discussing cardiac action potential, right? Previous class was on cardiac action potential, and before that we have discussed some electrophysiology of the membrane, definitions of resting membrane potential, how resting membrane potential develops into an electrotonic potential, and how electrotonic potential further develops into action potential, right? Okay, and we have known the shape of action potential in case of a neuron and in case of a cardiac muscle, right? And in cardiac muscle, we have discussed two different types of action potential. One is called the fast response action potential, which happens in the atrial and ventricular myocardium, and the slow response action potential, which happens in the conduction tissues like your SA node, AV node, bundle of His, and the Purkinje fibers, right? Okay. So we have also discussed the ionic basis of action potential, right? Ionic basis of slow response as well as fast response action potential, right? So this is the shape of action potential in different types of cardiac tissues, right? And here you can see the ECG. So our target is gradually we will be entering into ECG proper, right? But suddenly we can't enter into ECG unless and until you know the electrophysiology of this cell membrane, right? Because the background of ECG lies on the electrophysiology, right? Action potential travels in your heart, and externally we record it as ECG, right? And we can detect many rhythm disturbances, acute coronary syndromes or heart attack or electrolyte abnormalities from an ECG, right? With the help of this. Okay, so those who are quite new and joining classes right now, I have seen many hands are raising, right? So there might be a little bit problem in understanding, because the majority of the action potential, shape of action potential, ionic basis of action potential, everything has been discussed in previous classes, okay? So anyways, there is no issues. Classes may be repeated and definitely will be repeated, right? And ECG is such a topic that needs repetition, because whenever you will be a full-grown physician or a doctor, ECG will be your bread and butter, right? So you need to know ECG in details, right? Irrespective of your specialty, you be a physician, you be a gynecologist, you be a surgeon, whatever, right? ECG is a must for all, right? Because it is the basic criteria of IMG or Indian medical graduate to interpret an ECG, and definitely to identify an acute coronary syndrome or heart attack from an ECG, right, which is an emergency, and also the rhythm disturbances and electrolyte disturbances, okay. See, ECG is a big thing, and there are lots of books, you know, this much books on ECG, right. So everything is not possible right now, but the basic is always important, right? And in your undergraduate syllabus, what is essential is interpretation of normal ECG, number one. Number two, interpretation of ECG of acute coronary syndrome, right? That is heart attack. Next, interpretation of rhythm disturbances, interpretation of heart block, right? And interpretation of electrolyte abnormality, right? Like sodium, potassium, calcium. Okay, if low or high, what will be the effect in ECG? Okay, so coming back to our discussion. So this is the shape of action potential. It is in SA node, and this is in ventricular muscle. In ventricular muscle, we call it the slow response, fast response action potential, and in SA node, we call it slow response action potential. Okay. You can remember in this way, SA node, S for slow response, right? So SA node, slow response action potential, and ventricular myocardium, it is fast response action potential. Why slow response and fast response? Because this steep phase 0 is steep here, so it is called fast response action potential in case of ventricular muscle, okay? And I told that this is a very important slide and an MCQ zone for NEET PG or next PG, whatever, okay. So you can see the speed is highest in the Purkinje system, okay. Very often MCQ comes from this slide. So the highest speed of action potential is in. So options will be Purkinje fibers, SA node, AV node, and your answer will be definitely Purkinje fibers. So that is 4 meter per second, very important slide, okay. Now we have also discussed the pacemaker potential. okay, which happens in SA node, okay, and this is the ionic basis of action potential in ventricular myocardium. I'm recapping fast, right, okay. So this is the fast response action potential which happens in ventricular myocardium. So this is phase 0. Phase 0 is due to sodium entry. Phase 1 is due to transient outward potassium channel. Phase 2 is due to calcium in and potassium out. No need to ask, just enter. Okay. So calcium in and potassium out, and phase 3 is always due to potassium out, right. And here the resting membrane potential of myocardium is minus 96 millivolt, and at the top it is up to 52 millivolt. After firing, it goes top up to plus 52 millivolt. Okay, new students, those who have difficulties in understanding, you can come to me later on. Okay, in the department you can meet me definitely. Okay, and you can, if there is any problem in understanding. Okay, and always you can discuss with your fellow batchmates, right? So that is most beneficial. During your foundation course, I have always told that group study is best here in medical science, because we have lots of things to remember, lots of things to understand, and the syllabus is huge, right? You know, only anatomy syllabus is thrice the syllabus of your chemistry, 10 plus 2, right? Okay, so forget everything, don't forget what I have told. Okay, so here is the action potential in ventricular myocardium, and here is the same time frame. In the same time frame, if we superimpose ECG and action potential, it looks like this. Okay, so during phase 4 we get the P wave, and during this ventricular contraction phase we get the QRS complex, and during this downstroke, okay, during this downstroke, that is phase 3, we get the latter half of the phase 3 we get the T wave. Okay, it is in the same time frame. Okay, this is the same time frame if we superimpose ventricular action potential or the fast response action potential and ECG. Okay, so here is the ionic basis of action potential in SA node. Okay, ionic basis of action potential in SA node. You can see the phase 4 is due to calcium current and also F current. Okay, F current very important. I have told that again, it is a very important MCQ zone. Okay, so F current is called funny current or funny channel. It is also called HCN channel, hyperpolarization gated cyclic nucleotide activated ion channel, right? So during phase 4, these 3 currents are important. One is long lasting calcium channel, another is transient calcium channel, and another is funny current. And you see this, this line, this red line, blue line, green line, they indicates the time duration the channel is open during phase 4, right? So you see F current is open throughout phase 4. So F current is the most important current which is responsible for phase 4 action potential, or it is also called the pacemaker potential. Phase 4 is called pacemaker potential, right? Remember, phase 4 is pacemaker potential. Again, an MCQ zone. Okay. In SA node, which phase is called pacemaker potential? Now options will be phase 0, phase 1, phase 2, phase 3, right? Your options will be phase 4. Okay. So important, phase 1 and phase 2 missing in SA node. Okay. Unlike the action potential in ventricular myocardium, phase 1 and phase 2 missing. Okay. Phase 1 was due to transient outward potassium channel, and phase 2, the plateau phase, was due to, yes, calcium entry and potassium exit. Okay. And they were balancing each other, that is why voltage were remaining constant. Okay. So this is the action potential. Looks like in SA node. And next we have discussed how you can change heart rate by applying some drugs. Okay, how you can change heart rate by applying some drugs like a catecholamine, like adrenaline, like acetylcholine. Okay, so you can change the heart rate. So in many patients of, patients of heart failure, patients of acute ischemic heart disease, okay, many a times we need to change the heart rate of the patient so that the oxygen consumption is reduced and the workload or oxygen demand of the heart can be reduced. Okay, so we need to give some drug to the patient, right? So how can we change the heart rate? So number one, we can reduce the steepness of phase 4 action potential. Okay, so this orange color is the normal and the blue color is when we apply some drug which reduces the steepness of phase 4 action potential, right? Okay, so initially the steepness was high, okay, this tan theta, okay, this tan theta matters, right? Okay, so initially it was steep, right? Now after applying some drugs, so slower depolarization require more time to threshold, okay, so decreased rate. So you see 3 spikes over here, 3 spikes normally, but when we apply the drug, we see only 2 spikes, right? So heart rate is reduced, okay. So steepness of phase 4 action potential can be reduced by applying some drug, and we have told you the drug, the name of the drug. Yes, the name of the drug is Evabradine. Okay, the name of the drug is Evabradine, not required for you. Later on in your pharmacology, you will study details about Evabradine. So Evabradine is a drug which we use in ischemic heart disease and also in heart failure to reduce heart rate, okay, to reduce the oxygen demand by the heart, right? So Evabradine works on the F current, funny current, okay, it blocks the funny current or HCN channel so that the steepness of the phase 4 action potential in SA node is reduced, right? Okay. Next another thing that can be done is to reduce the maximum diastolic potential, okay. The lowest point in the action potential, this is the lowest point in the action potential normally, and this is when we apply some drug, okay. So maximum diastolic potential can also be reduced to reduce heart rate, okay. Okay, so this maximum, this point is called maximum diastolic potential and it is reduced to this by applying some drug. So it is called negative shift in maximum diastolic potential. That can also be done. Okay, now positive shift in the threshold. It is also can be done. Positive shift in the threshold. So initially the threshold was this. This orange color was normal and this purple color is new after applying some drug. So initially this was the threshold and the new threshold is this. Threshold point is where the action potential is firing, okay. So initially this was the threshold and now this point is the threshold, right? Okay. So positive, reaching a more positive threshold requires more time, so that is why heart rate is also reduced, right? Okay, now action potential, what are the acetylcholine? What are the functions of acetylcholine? Acetylcholine, it reduces the steepness of the phase 4, number one, by acting on the funny current. Not only Evabradine, acetylcholine also acts on the funny current, right? Acetylcholine has multiple actions, right? So it reduces the steepness of the phase 4 action potential and it can also reduce the maximum diastolic potential of the SA node towards more negative, right? So in all ways acetylcholine will reduce heart rate, it will reduce your heart rate, right? Okay, by acting on the funny current, by acting on the GIRK, which is a specific acetylcholine sensitive potassium channel, and also on the calcium channel, okay. So while acting on the funny current and while acting on the calcium channel, acetylcholine reduces the steepness of phase 4 action potential, and by acting on, try to understand, don't write, okay, I can share this PPT, no issues, okay, I can always share this PPT to anybody, right? So this is absolutely open, no need to write, no need to take a snap, just get the PPT from me, right? Yes, if I tell anything which is not written over here, you can definitely write, okay. Okay, after the class you remind me, I will share the PPT in your group. Okay, so acetylcholine, it is better to understand because in physiology I always tell ki it is conceptual, right? And I will tell when there are points to remember. Okay, there are many points to remember as well, not only concept. Okay, so acetylcholine acts on the funny current, it acts on a specific potassium channel which is called GIRK, it also acts on the calcium channel. By acting on the funny current and by acting on the funny current and by acting on the calcium channel, it reduces the steepness of phase 4 action potential, and by acting on the potassium channel, it reduces the maximum diastolic potential. So in all ways, acetylcholine reduces your heart rate. So if I give acetylcholine to a patient, patient's heart rate will drop. Okay? patient's heart rate will drop. Similarly, if I give Evabradine to the patient, again patient's heart rate will drop, right? But yes, Evabradine is safer and specific because acetylcholine has much more effect on your body, but Evabradine is more specific. Evabradine has only the fast action, which decreases the funny current, which blocks the funny current and reduces the steepness of phase 4 action potential, right? So whenever there is requirement to reduce the heart rate of a patient, we can give acetylcholine to the patient, we can give Evabradine to the patient, okay? And it is very specifically, Evabradine is very specifically used in heart failure and in acute coronary disease or ischemic heart disease. Okay, now catecholamines. Catecholamines means adrenaline, noradrenaline, okay? You have heard the name of yes, it's good. আগে তো ইয়ে হলে মানে পাওয়ার অফ হলে এটাও চলে যেত, তো এখন এটা ঠিক হয়েছে, তাই তো? গ্রেট, ইটস গুড টু সি থিংস আর ডেভেলপিং। ওকে, সো catecholamines, okay, that means what are the effect of adrenaline on heart? What are the effect of adrenaline on heart? So increase IF, so increase steepness of the phase 4 potential, so it will increase your heart rate. So if I give adrenaline to the patient heart rate will increase, okay, patient's heart rate will increase, okay. Also increase in the calcium channel, increase in the calcium current, ICA, and phase 4 depolarization that make the threshold more negative. So catecholamines, maximum diastolic potential, it will not change the maximum diastolic potential, right? It will not change the maximum diastolic potential, it will increase the steepness and threshold will be more negative, okay, threshold will be more negative. So in both ways heart rate will increase, okay, in both ways heart rate will increase. If I give adrenaline to the patient heart rate will increase. So when do we need to increase the heart rate of the patient or increase contractility of the patient? Maybe the patient is in shock, okay, patient is in shock, hypovolemic shock, we need to get more contractility, right? We may give adrenaline to the patient, specifically we use noradrenaline nowadays, okay. So here comes the refractory period, okay. So refractory period will be told in details during nerve muscle physiology. Here only for cardiac part I am telling you the refractory period. So here is the total refractory period. Refractory period means your cardiac muscle will be refractory for another stimulus. It will not accept another stimulus, right? It will not accept another stimulus. So when a muscle is contracting, when an action potential is being generated, right, during the phase of action potential, it will not generate another action potential, okay. So this time is approximately 200 milliseconds, okay, from this point to this point. So it is a graph basically, right? Here x-axis is time and y-axis is voltage, right? So in x-axis if we see, this time duration is 200 millisecond, and during this 200 millisecond it will not accept another action potential, okay. ऐसा नहीं है कि यहाँ पर action potential फिर यहाँ पर stimulus दे दिया फिर और एक यहाँ पर हो गया, ऐसा नहीं होगा, ठीक है. So throughout this duration it will not accept another stimulus, right? So this is called the refractory period. This is total refractory period and this is absolute refractory period. So at the midpoint of phase 3, up to the midpoint of phase 3 is your absolute refractory period, and uske baad there is relative refractory period, right? There is another thing called SNP. SNP is called supernormal period, okay. Supernormal period is a brief phase. It occurs at the end of relative refractory period, and typically in cardiac muscle and neuron, the excitable cells, where the excitability temporarily increases. So during this time, minimum stimuli or maybe weaker than normal stimuli, subthreshold stimuli can trigger another action potential. So this is called supernormal period, okay. The hard question, it will not be asked usually, okay, until and unless you are answering very well, okay. So during your Viva examination, what happens? We start with very basic question, okay. So if you are able to answer, we step up, okay, we step up, harder question, then or harder, right? So gradually we step up, okay, and once you tell very well, you get an honors marks, right, or very good marks, right, okay. So supernormal period is a thing which can be asked after crossing many steps, okay. Okay, so supernormal period is a brief period that occurs towards the end of relative refractory period, जहाँ पर क्या होता है कि थोड़ा सा स्टिमुलस या फिर सब थ्रेशोल्ड स्टिमुलस जो एक्शन पोटेंशियल जनरेट कर सकता है, right? Very weaker stimulus can generate action potential, right? And the supernormal period is clinically relevant in cardiac tissues where conduction can unexpectedly normalize, particularly in the setting of abnormal or intermittent block, conduction block. So conduction block abhi आप लोग पढ़े नहीं हो, right? So once you understand what is conduction block, so then I will again repeat this. Okay, so once there is conduction block, suddenly the patient may be normalized. Okay, conduction may come back, normal conduction may come back due to the presence of this supernormal period. Okay, so if we compare it with ECG, this is the P wave. Okay, so starting from the QRS complex to the half of T wave, we get the absolute refractory period, and the latter half of the T wave, we get the relative refractory period. Latter half of the T wave, we get the relative refractory period. You know the waves of ECG? This is P wave, right? This is P wave. This is P wave, and this is QRS complex. This chota sa downstroke is called Q. Okay, this chota sa downstroke is called Q. This one is R. Okay, this is S. This point is S. Okay, and this total dome is T wave. Okay, so ECG is nothing but PQRST, 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 right? Okay, so I have shown this. This is the superimposition of cardiac action potential and 12 lead ECG, right? Now, a few clinical part. I have talked everything about Evabradine. Evabradine is a IF blocker or funny current blocker. So another two things is Digitalis. So Digitalis is a drug which is used heart failure when the heart is not pumping. Okay, when the heart is not pumping adequately, we give Digitalis to the patient so that the contractility is improved, right? So by giving Digitality, cardiac contractility is increased because more calcium accumulates within the myocardium. Okay, but Digitalis is not used nowadays because of its toxicity potential, right? There are many safer drugs available nowadays to treat patients of heart failure, but previously Digitalis were used, digoxin or Digitalis were used in the treatment of heart failure. Okay, so many times we ask in physiology what is the mechanism of action in Digitalis in heart failure. Okay, heart failure में Digitalis कैसे काम करता है, right? So you need to write the answer. Okay, so Digitalis primary mechanism is sodium potassium ATPase, which is present at the cell membrane. Sodium potassium ATPase, which is present at the cell membrane. You know sodium potassium ATPase? Okay, 3 sodium out and 2 potassium in. Okay, it is an active transport. Okay, transport across cell membrane is a separate class, and that will be dealt in general physiology, right? So sodium potassium ATPase is an active transport which is present on the myocardial cell membrane. It causes 3 sodium out and 2 sodium in, right? So primary action of Digitalis is to block this sodium potassium ATPase. Okay, so once this sodium potassium ATPase is blocked, okay, sodium accumulates inside the cell, and as a result, there is activation of sodium calcium exchanger. Okay, activation of sodium calcium exchanger, and this sodium calcium exchanger, it causes increased calcium accumulation within the cell, and as a result, the contractility of the myocardium is increased. Okay, so previously, before Digitalis, the heart were not pumping adequately. Now the heart will pump vigorously. Okay, with the effect of Digitalis. Okay, so we use this in the treatment of heart failure. But remember, nowadays far more safer drugs are available to treat the patients of heart failure because Digitalis has got toxicity potential. Okay. So LQTS is long QT syndrome. So long QT syndrome, right now you don't know what is QT interval. So I will come back to LQTS, long QT syndrome, later on in subsequent classes of ECG, because ECG needs at least 4 to 5 classes, right? It's a big topic. Okay, so after discussing ECG, we will come back to LQTS. Right now, just remember, it is a genetic syndrome or genetic disease, long QT syndrome. So in ECG, we measure a particular interval called QT interval. Okay, called QT interval, and when this QT interval is prolonged, we call it long QT syndrome, and it is due to genetic mutation of different ion channels. Those are responsible for action potential in myocardium or SA node, right? So this genetic LQTS1, there are different types of LQTS, LQTS1, LQTS2, but the commonest one is LQTS1, which is LQT1, which is due to a potassium channel mutation, KCNQ1 channel mutation, right? Okay, and when there is, what is the problem with the patient of LQTS? जब patient को LQTS होता है, मतलब the patient who are having LQTS, because LQTS is a concealed disease, right? हमें पता नहीं चलता है कि कौन से patient को LQTS है, long QT syndrome है, ठीक है? क्योंकि patient को कुछ symptoms नहीं होता है, right? The patients do not have any symptoms, but suddenly for some another reason we perform ECG of the patient and we see the QT interval is high, right? QT interval is high, and the patient is having LQTS or long QT syndrome. Patients usually will have no problem, but there is a chance of sudden cardiac death during heavy strenuous activity. Okay, you have heard in recent times, many times, that someone in the football ground suddenly collapses and there is death, and someone in the gym, okay, during heavy lifting suddenly collapses and death, right? So those patients might be having LQTS, long QT syndrome, right? Okay, these are MCQs we will deal later on, because we will not be able to answer these questions right now. আচ্ছা, এবার আরেকটা ইয়ে আছে, escape মারো। হচ্ছে না কেন? Okay, so cardiac vectors. Okay, so right now we are coming to cardiac vectors. Okay, সাউন্ডটা কমিয়ে দাও, এখানে সাউন্ডটা। ওকে, এই স্পিকারের সাউন্ডটা কমবে না? এটার ব্যাকগ্রাউন্ডে একটা অডিও আছে। হ্যাঁ, হয়েছে, ঠিক আছে। Okay, so now fresh, another thing I will start. Okay, another very important thing I will start, that is called cardiac vectors. Okay, cardiac vectors, you know vectors, right? From your physics knowledge, you know what is vectors. It has got a magnitude, it has got a direction, right? And it can be measured, right? Okay, like the speed, force, right? Okay, these are vectors in physics, right? It has got a magnitude and it has got a direction. Okay, so not exactly vectors, but we assume the flow of action potential. Okay, I have given you the concept of flow of action potential, how action potential travels. Okay, how action potential travels throughout your myocardium. Okay, how action potential travels throughout your myocardium, because the cardiac muscle cells are connected to each other by a special structure. Do you remember? Do you remember? Cardiac muscle cells are connected to one another by a special structure. Yes, very nice. Gap junctions. Okay, so gap junctions are electrical coupler. Okay, electrical coupler for cardiac muscle cells. And I have given you the examples of this hall. Okay, if we consider this hall as your left ventricle, okay, as we consider this hall as your left ventricle, okay, and each brick in the wall is a cell, is a myocardial cell. So if one brick is depolarized, the brick surrounding it will be depolarized. Okay, and this is possible because of the presence of gap junctions, which is helpful, gap junction is helpful in transmitting voltage from one cell to another. Okay, so first, SA nodal cells are depolarized because of the pacemaker activity. Now once SA nodal cells are depolarized, this depolarization wave travels like a Wi-Fi signal, right? Depolarization wave, it travels from atria to ventricle and it depolarizes the whole heart. Okay, right? This is the mechanism. Okay, so for any chamber of the heart to contract, like your left ventricle, say this is left ventricle. Okay, so one brick in the wall is depolarized. Now it will send depolarization wave to the neighboring cell. All the neighboring cells are depolarized. Okay, they will also send depolarization wave to the neighboring cells. Now gradually the total hall will be depolarized. Once the hall is depolarized, hall will contract. okay, and you will be ejected out. Your blood, okay, and you will be ejected out, right? So hall will contract, you will be ejected out. So this is how happening. Left ventricle will contract and blood will eject out through the aorta, right? Okay, so for contraction, what is required? Depolarization. Okay, total ventricle should get depolarized for contraction, right? So depolarization wave is basically what? Basically action potential. It is traveling from one cell to another. Okay, it is basically action potential traveling from one cell to another, and it has got a value, it has got a direction. That is why we call it vector. Okay, so vector is, cardiac vector is a depolarization wave, or simply it is an action potential that is traveling from one place to another. Okay, okay. So there are 5 vectors that operates within the total cardiac cycle of 0.8 second. Normally cardiac cycle is 0.8 second, you know, right? So within this period of cardiac cycle, one cardiac cycle or 0.8 second, there are 5 electrical vectors that operates within the heart. Okay? Now come to the fast electrical vector. Yes. So this is these are my hand drawn. Okay. I am not good in drawing, so but it is easy for understanding, right? Okay. So this is the cardiac chambers, 2 atria and 2 ventricle, right? So here is your right atria. Okay. So fast vector, it travels from atria to, this is SA node, this is the location of the SA node, right? This is the location of the SA node, and it travels in this way towards down and left, right? Towards down and left. So I am moving in this way. So consider this is my heart. Okay, this is my heart. So fast vector is traveling in this direction, down and left, right? Fast vector is traveling down and left. This is called atrial depolarization vector. Okay, atrial depolarization vector. Okay, I need to draw something. So if this is your atria, this is SA node, the vector is this, right? Okay, but actually the vector is not this. Okay, so there are lots of vectors that travel from SA node and it depolarizes the whole atria. Okay, so there are lots of vectors. Okay, so from SA node it just spreads, lots of vector travels and it activates or depolarizes the atria, and the resultant vector is this. Okay, the resultant vector is this. You know what is resultant? The sum of all the vectors. Okay, so the resultant is this. So fast vector which operates from atria towards the left ventricle is this. In case of my heart, it is this. Okay, so this is the fast vector. We call it atrial depolarization vector. Okay, we call it atrial depolarization vector. Okay, everyone clear with atrial depolarization vector? So whole atria is being depolarized in this direction, we can consider, right? Okay, now this second vector. Okay, second vector is called the septal depolarization vector. Second vector is called the septal depolarization vector, which depolarizes the interventricular septum, and the direction is from left to right. Okay, direction in case of my heart it is this. Okay, this. Okay, from left to right. Okay, this is called septal depolarization vector. This is how your interventricular septum is depolarized. Okay, second vector. So first vector is atrial depolarization vector, second vector is septal depolarization vector, right? Okay, now the third vector. Third vector is depolarization of the cardiac apex, okay, or the apical depolarization vector, depolarization of the cardiac apex, and its direction is quite same as that of atrial depolarization vector, but magnitude is much larger. Okay. Okay, everyone notice the length of the arrow. Okay, this length of the arrow, it matters because it denotes the magnitude of the vector, how strong the vector is. Okay, how strong the depolarization wave is. Okay, so previously in the septal depolarization vector, it is a small vector. Okay, its direction is this, but it is not strong enough. It is weak. Okay, it is weak, right? Okay, now this depolarization of the apex, it is a strong vector which depolarizes your cardiac apex. Clear? Okay. Now the fourth vector. Fourth vector is the vector which depolarizes the free wall, ventricular free wall. What is ventricular free wall? So here is your left ventricle, this is the free wall and this is the wall attached to interventricular septum, right? This is the left ventricular cavity, and this is free wall. This is ventricular free wall, we call it ventricular free wall, and this is the, and this is the interventricular septum. So this is called septal wall and this is called free wall, right? Okay, so this is free wall and this is septal wall, and fourth vector is the vector, or it is the collection of vectors. Fourth vector is the collection of all vectors which depolarizes the ventricular free wall. Okay, and if we combine all these vectors which are fanning out towards the ventricular free wall, we get a resultant vector and it is this. Now tell me from your knowledge or your concept, why this is the left ventricular free wall and this is right ventricular free wall. Why the combination of all these vectors which depolarizes ventricular free wall get the resultant which is oriented towards left and not towards the right? Yes, very nice. So the thing is, the more is the muscle mass, more depolarization you need. Okay, and your left ventricle is thicker with higher muscle mass than your right ventricle, right? So these vectors are strong enough. Okay, so the vectors which depolarizes the left ventricular free wall are stronger than the vectors which depolarizes the right ventricular free wall. Okay, you see these arrows are longer, and these are shorter, right? Okay, so resultant you get this, which will be oriented towards left. Okay, so in my heart this vector is this. Okay, this. Okay, so this is the fourth vector, which is called ventricular free wall depolarization vector. Ventricular free wall depolarization vector. Now the fifth vector. Fifth vector is the posterobasal part of the heart depolarization vector. It is also a very small vector. Okay, posterobasal part of the heart depolarization vector. So these are 5 vectors. To recap, first vector is atrial depolarization vector. Second vector is septal depolarization vector. Third vector is apical depolarization vector. Fourth vector is ventricular free wall depolarization vector. And fifth vector is posterobasal part of heart depolarization vector. Posterobasal part depolarization vector, right? So these are 5 vectors. Okay. Okay. Now what to do with these 5 vectors? Eta jene ki hobe? Yes, these 5 vectors are required, and these 5 vectors are captured by your ECG machine. Okay. So ECG machine is nothing but to capture these electrical vectors from the surface of your skin. Okay, heart is inside. ECG is a non-invasive investigation where we don't need to prick the patient, where we don't need to injure the patient by cutting or anything, right? By cutting or inserting a needle or anything. It is totally non-invasive, right? So just over the chest wall and over the limbs, we apply some leads or electrodes, right? And we get the ECG wave, okay? And the ECG wave is generated because of these 5 vectors. Okay, and when these 5 vectors are abnormal, your ECG shows some abnormality, right? So your ECG is nothing but the interplay of these 5 vectors. Okay, so in the cardiac cycle of 0.8 second, these 5 vectors operates. Okay, these 5 vectors operates. 1, 2, 3, 4, 5. Okay, again 1, 2, 3, 4, 5. Okay. This 1, 2, 3, 4, 5, 1, 2, 3, 4, 5 happening and you are getting ECG. 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, right? You get PQRST, PQRST, PQRST. Okay, in your ECG. Okay. Now, next what you need to understand is the concept of leads or the clips which we apply to the patient, right? During ECG recording, right? Okay, so it will be discussed in detail during practical class with the ECG machine itself, because this is a lecture class, but I will give you the concept of ECG leads. First concept is what is a lead, okay? Simultaneously we need ECG practical in your practical session so that your understanding is better. We will try to start ECG in your practical as well. In your practical right now it is hematology, right? Hematology, what is happening? Differential leukocyte count. Okay, okay, I will try so that ECG practical runs simultaneously so that your theory and practical knowledge integrates, right? Okay, so in the department we have ECG machines. We will perform ECG in the practical class, right? Okay. Okay, now ECG leads. What is a lead? The definition of lead is a pair of electrode. Okay. The lead is a pair of electrode. Two electrodes and a voltmeter. Okay. So here is a point A and here is point B, right? So we connect point 1 and point B with electrode and connect it with a voltmeter, and the voltmeter will give you the result VA minus VB. Okay, the potential difference between point A and point B, right? This setup is called a lead. Okay, when we connect two electrodes with 2 points, okay, in 2 points, when we connect 2 electrodes and in between we connect a voltmeter, it forms a lead. Okay, so ECG lead is a pair of 2 electrode and a voltmeter in between, right? Okay, so in ECG we have 12 leads conventionally. Okay, conventionally we have 12 leads. There are 6 limb leads and 6 chest leads. Okay, 6 limb leads, that means the lead which we connect to our extremities, hand, foot, right? Which we connect to our extremity, and there are 6 chest leads. Chest leads are designated with V. So V1, V2, V3, ऐसे करके V6. Okay, V1 to V6 all are chest leads that we connect here. Okay, chest leads 6, 1, 2, 3, 4, 5, 6. So 6 chest leads we connect here, and the limb leads we connect here, here, and left foot. Right? So these are leads. Okay. Now you need to know what is lead 1, what is lead 2, what is lead 3, what is lead AVR, AVF, AVL, and V1 to V6. So there are 6 limb leads and 6 chest leads. Okay, 6 limb leads are 1, 2, 3, AVR, AVL, AVF, and 6 chest leads are V1, V2, V3, V4, V5 and V6. Okay? So these are total 12 leads in ECG. Okay. 1, 2, 3, these are called the traditional limb leads, and AVR, AVL, AVF, these are called augmented limb leads. Augmented limb leads. This small a signifies augmented. Okay. Now the formation of the leads. Next concept is the formation of the leads. How ECG leads are formed. If I stand like this, okay, okay, you connect my right wrist, left wrist and left foot, you get a triangle, right? If I stand like this, okay, if I connect my right wrist, left wrist and left foot, right, you get a triangle, right? I am drawing the same triangle over here. Okay, this, okay. So right, I am calling it right arm, left arm, and this is left foot. Okay. Okay. Now if I attach one electrode here and connect it with a voltmeter, I can do that. Okay. So I am placing, ECG machine can be manufactured. So let us manufacture an ECG machine. Ekta ECG machine amra toiri kori, right? Let us build an ECG machine. So ECG machine banane ke liye hame kya chahiye? Few copper wires. Okay, few copper wires and few voltmeters. ECG machine is nothing but collections of many wires and voltmeters, multiple voltmeters. Okay. So first take a copper wire, insert here, again another copper wire, insert here and connect it with a voltmeter, right? So copper wire, voltmeter, correct? It is lead 1. Okay. In ECG it is lead 1. Okay? It is lead 1. So lead 1 is essentially the potential difference between RA and LA. Okay? VRA and VLA, right? Lead 1 in ECG, it detects the potential difference between the point RA and point LA, correct? Again take a copper wire, take another copper wire, connect with voltmeter, right? It is your lead 2. So lead 2 is the potential difference between RA and LF, correct? Lead 2 measures potential difference between your right arm and left foot, right? Lead 3, again take copper wire and a voltmeter, right? So lead 3 is the potential difference between LA and LF. Correct? So see, we have already built 3 leads of ECG. Right? We have already built 3 leads of ECG. Okay? Now, what is AVR, AVL and AVL? Right? What is AVR, AVL and AVL? Okay? So here, one example I will show, and the remaining part you need to assume, right? So let us build a lead called AVR. Okay, AVR. Oh. Okay, so let us build AVR. How to build the lead AVR? AVR আমরা কি করে তৈরি করব? Now, take 2 copper wires. Take 2 copper wires. One insert in my left arm, another copper wire insert in my left foot. ठीक है? So one in left arm, another in left foot. 2 copper wires and make a common terminal. Right? One insert in left arm, another insert in left foot and make a common terminal. Okay. Then take another long copper wire from RA and connect it with this common terminal. Getting my point or not? Okay. So it is AVR. Okay. Correct? Now you know what is AVL and what is AVF. So AVR equal to RA minus ठीक है? Getting or not? So similarly, AVF is equal to LF minus clear? So to form AVR, you need to connect LA and LF, make a common terminal and connect it with RA in between a voltmeter, right? To make AVF, to make AVF, you need to connect RA and LA, make a common terminal, connect it with LF. So what we need to do, মানে অগমেন্টেডলি বুঝতে পারিস নি তো এলএফ এভিএফ এভিএল এগুলো বুঝতে পারিস নি তো বাকিগুলো বুঝতে পেরেছিস তো হোয়াট ইজ লিড 1 2 3 বুঝতে পেরেছিস ওকে সো আজকে এই পর্যন্তই হবে এর বেশি হবে না রাইট ওকে সো টু ফর্ম এভিএফ ওকে আমি সবগুলো মুছে দিচ্ছি তাহলে ক্লিয়ার হবে To form AVF, here is RA, here is LA, and here is LF, right? তাহলে I will take 2 copper wires, আমি দুটো copper wire নেব, right? কপার ওয়্যারটা কোথায়, একটা এখানে ফোটাবো, একটা এখানে ফোটাবো, সত্যি করে করবি না কাউকে, ঠিক আছে? আচ্ছা আচ্ছা, তো একটা কপার ওয়্যার আমি রাইট আর্মে ইনসার্ট করলাম, একটা লেফট আর্মে ইনসার্ট করলাম, রাইট, দিয়ে একটা কমন টার্মিনাল করলাম, হিয়ার ইজ এ কমন টার্মিনাল, রাইট? সো এই পয়েন্টে পোটেনশিয়াল ডিফারেন্স হচ্ছে দুটোর অ্যাভারেজ, ওকে ওকে, এই কমন টার্মিনালটার সঙ্গে এইটা কানেক্ট করলাম, ঠিক আছে? তাহলে আর এ প্লাস এল এ বাই টু আর এল এফ তার ডিফারেন্স, এল এফ আর আর এ প্লাস এল এ বাই টু তার ডিফারেন্স হচ্ছে এভিএফ। ক্লিয়ার? এবার ক্লিয়ার কিনা সবার? ওকে আচ্ছা, এবার আমি সব লিডগুলোর ডিরেকশন দেখব, সব লিডগুলো কোন ডিরেকশনে আছে ইন এ coronal plane. You know from your anatomy knowledge what is coronal plane, what is sagittal plane, what is transverse plane. Okay, so this is my coronal plane, right? This is coronal plane and this is sagittal plane and this is transverse. Okay. So here is lead 1 from RA to LA, okay. Conventionally this side is positive, this side is negative, okay. So this is lead 1, this is lead 2 and this is lead 3, okay. And you know for vectors we can parallelly shift, right? If a vector is this, I can shift it parallelly. So its direction and magnitude remains the same, right? So if this is lead 1, I can draw lead 1 from a center point. So lead 1 is this, correct? This is lead 2, so the direction is this, and this is lead 3, so the direction is this, okay. Now I will remove the triangle. Right, I will remove the triangle, okay. Triangle removed, this is lead 1, this is lead 2, this is lead 3, okay. And at the center you have the heart, correct? Do you remember the first vector? Okay, first vector is atrial depolarization vector, right? ये किसके तरफ आ रहा है, कौन सी लीड के तरफ? लीड 2 के तरफ, right? So you get a positive wave, right? Second vector was the septal depolarization vector, छोटा सा, remember? This chota sa, here is lead 2, so this chota sa vector, is it coming towards lead 2 or it is going away from the lead 2? Away from the lead 2, so you get away from the lead 2, so you get a negative wave, right? Next vector, apical depolarization vector, okay, towards, this is apical depolarization vector towards lead 2, this is lead 2, right? Towards lead 2, so you get a big, right? Now the next vector is ventricular free wall depolarization vector, which is this, towards lead 2 or away from lead 2? Away, you get a negative wave and you formed this P, Q, R, S of ECG, right? PQRS is formed. Now what is T? Repolarization, okay. If a depolarization wave, this is the lead, if a depolarization wave comes towards the lead you get a positive wave, right? If a depolarization wave moves away from the lead, you get a negative wave. Okay. Now after depolarization, heart has to repolarize. Contract hoyi to boshe thakbe na, it need to relax, right? It need to relax, it need to go to diastole, right? So the heart will repolarize again. After depolarization, it will come back to the resting membrane potential, it will come back to polarized state. It is called repolarization. Okay, it is called repolarization. Now as depolarization wave in the heart, depolarization wave travels as a, right? Total depolarization wave travels as a, but the repolarization wave travels ulta. This is the repolarization wave, right? Repolarization wave. So this is the base of the heart and this is the apex of the heart. So depolarization wave overall travels base to apex, but the repolarization wave, it travels apex to base. Okay? Okay. Now depolarization wave coming towards the lead gives you positive wave, positive deflection in the ECG, right? Similarly, repolarization wave coming towards the lead gives you negative deflection, but repolarization wave going away from the lead will give you positive deflection. Okay. So depolarization wave coming towards the limb, that essentially means repolarization wave moving away from the limb, right? Because in both the case you get positive deflection, correct? Okay, now the heart will repolarize. The repolarization wave travels like this. Repolarization wave travels like this, right? So this is repolarization wave, repolarization. Okay? So repolarization wave moving away from lead 2, this is lead 2, repolarization wave moving away from lead 2, so you get a positive wave, T. You have formed the ECG, PQRST, right?